Welcome to the Chase MedSearch podcast, the place where we dive deep into the medical device sales industry by discussing the current trends, timeless philosophies, and amazing experiences that shape our niche of the industry. Join me, Jordan Chase, on a guided tour as I speak with established sales leaders and professionals as they share stories that will help you get in, stay in, and thrive in your medical device sales career. Let's start the show. Welcome back to the Chase MedSearch podcast. My guest today is Dr. Arun Gupta, a distinguished physician practicing in primary care for 35 years and in the addiction medicine space for the past 15 years. He's passionate about making a difference in the opioid crisis that is devastating so many lives in the United States, and is the author of a book, The Preventable Epidemic, a frontline doctor's experience and recommendations to resolve America's opioid crisis. He lives in Monroe, Michigan, and he and his wife have 3 grown children, all of whom are medical doctors. Dr. Gupta, welcome to the Chase MedSearch podcast.
Jordan, thank you for having me here. It's an honor.
Well, it's a pleasure to have you on. I have to make a slight confession. I'm from Michigan, born and raised, grew up there, lived in the state till I was 24. I do not have a clue where Monroe, Michigan is. Where is that?
It's just 20 miles south of the Detroit airport and 12 miles north of Toledo, Ohio.
Got it. Thank you. You tested my knowledge of geography when I saw where you were from. Is that considered a rural area, Dr. Gupta?
It's a rural area, yes.
Rural area. Terrific. There's a gripping quote from your book that says, "I can't retire, not until the opioid epidemic finally becomes a chapter in our nation's history." Clearly, this is a personal subject that you're passionate about. How did you develop that passion?
Well, nothing specifically happened in my life, personal or extended family. We're all doing well thanks to the life I had as a physician. The local community, the county, the state, the city has been very fortunate for us. And I thought this is a way of giving back. Mm-hmm. And I, as an addiction provider, I find there is a lot of regulations, restrictions, and limits that have been imposed on the doctors that prevent doctors to provide the care that is necessary to save people's life. At the same time, it's impossible for patients to get the care. And while I was writing the book, and I said, what should I do? So I made a goal, at least, so long as I'm healthy and alive, I'm 68, to keep working and fighting for the same cause. Because most physicians, most bureaucrats and politicians do not know how to solve this problem. And I researched myself for 5 years and asked myself questions every day when I went to bed and when I woke up, and did more research. And that's how I ended up coming with the book 2.5 years ago. So,
yeah. And just, scanning the book and reading, first off, you're a good writer. You're engaging. And I liked it. And it moves at a really good pace. I recommend everybody go out and either buy it or get it on Audible. I think it's on Audible as well. I saw that.
Yeah, it's 9 hours on Audible only. Okay. And for a lot of working people, everybody drives an hour or 2 every day. So, we can literally listen to it within 1 week.
Yeah. To establish the fact that we've got a crisis going on in this country, the statistics would boggle the mind. But I looked at one in 2022, the National Institute on Drug Abuse estimated 81,806 people died from opioid overdoses. But in listening to another podcast you're on, the real number may be higher. I heard you mention that patients who die of respiratory failure, who got a tube inserted, might not be counted in that figure. Is that right?
Yeah, so that's a totally different ballgame. So the 82,000 number has been revised, and in the last 3 years, it's been over 100,000 deaths annually. Last year was 114,000.
Wow.
Before it was 109,000. And before that was 104,000. So they're just releasing the data for a few months. They're lagging behind a year for whatever reason. But in the last 5 years, I would estimate at least 500,000 people have died from a disease that's treatable like any other condition, is preventable overdose deaths, and people were found to be dying accidentally. So it's not like somebody is trying to kill themselves.
Yeah.
The problem started with the OxyContin phase 25 years ago, or nearly 30 years ago. That was the first phase of it. And by 2010, as the government tried to put the brakes on OxyContin, fentanyl took over. That was the second phase, and the death rates went from 10, 12% to 15% overdose deaths. And when the third phase started with the fentanyl, the death rates went up to 30 to 40% over the last 4 or 5 years.
Wow. So if I heard that right, in attempting to curb it, it actually accelerated the problem.
Yeah, it did. It accelerated because the access to care was restricted and fentanyl was easily available. And I hate to bring this, a lot of these people got a lot of free money, and that probably went towards the drugs too.
Yeah, there's a whole history of how we got here today, and it's extensive and it's deep. And I think we should set the table for that as well a little bit.
Sure.
But your book offers practical solutions too.
Yeah, it does.
So that's how I hope to spend the majority of our time is I think every American should care about practical solutions for the war on drugs. And the fact that there even is a solution in reach when I think many people just say, you just got to throw up your hands. We're never going to solve this. But if you could just set the table for us, how did we arrive here at this point in history with America suffering the most opioid deaths of any country in the world?
So if I go back about 110 years, Harrison Narcotic Tax Act that was from 1914 that was trying to control the trade of illegal drugs around the world and obviously the money. And it said a few things. Addiction is a moral failing and is not treatable. And a doctor cannot prescribe any addictive medicine for another addictive condition. So the first medicine that came out was methadone about 50 some years ago. And that's doctors can't write it. So it's only being given from the federally funded clinics called OTPs or methadone clinics. And there are few of them in each state, easily accessible, sometimes 400, 200 miles. Then in 1999, CDC for the first time said 16,000 people had died of poisoning. 106th Congress studied this problem for about a year and a half and came up with the Data 2000, which allowed any practicing doctor to take a limited course, pass an exam, apply for an X waiver. That's how I learned in 2006. Mm-hmm. But it put so many limits, regulations, and oversight into it. I'm very proud I was able to learn addiction medicine from that system, but that was the beginning of the criminalization of the treatment arm. Mm-hmm. So then in 2002, Suboxone was approved, buprenorphine. If you look at it carefully, in 2002, OxyContin was at the peak, and we had a treatment medicine that's overly regulated, restricted, a life-saving drug. If in place of OxyContin, if it was Suboxone that took off, we wouldn't have this problem. If we didn't put any restrictions and regulations, we wouldn't have this problem.
Interesting.
And then in 2005, the federal government relooked at the Data 2000 and said the program was useful, but there's a little bit of diversion of the medication, but nobody was dying from it and hardly anybody was abusing it. But they still put a diversion control plan on the treatment arm, which was the second step towards criminalization. And then in about 5-6 years ago, the federal government sued the company that made Suboxone because some of it was being traded on the street for $2 billion. Now, OxyContin people got off the hook by $4 billion, and the treatment arm is on the hook for $2 billion. So these are the kind of problems that we face and the system faces that has led to this problem.
And that drug, Suboxone, is that an effective drug?
It's a life-saving drug, yes. I have 85% success rate. It binds to the mu opioid receptors in the brain. Once the narcotics leave, then no narcotics work on it. So if my patient has to go for an elective surgery, we withdraw the medicine for 3 days, and then people can get narcotics in the hospital. And most of my patients are back on the same medicine. So it is a life-saving drug proven over and over again, but it's still very restricted, limited, and regulated, and that creates a problem for doctors to prescribe it. And then there is no education for doctors to learn addiction or pain. They should have started in the year 2000, changed the ACGME program, ACGME to change the medical school curriculum, and educate all the doctors in learning addiction for medical school. Had they done that, we would have 500,000 physicians in this country fully trained and ready to go, and we didn't have a problem.
Interesting. Very interesting. So as you look at this, that's how we got to where we are today. I think a lot of people should be interested in solutions. Is Suboxone in your mind and in your research and based on your experience, is that the solution? And if it is, what needs to be done there?
Well, the solution comes is several levels. So before we talk about Suboxone as a solution, we need to see what are the problems. One problem is we didn't talk is the stigma towards the disease, the stigma towards the treatment, and then stigma towards the success of the treatment. So until unless we work on those factors, nothing is going to change. So even though the Supreme Court ruled in 1962 that addiction is not a moral failing, it's treatable condition, nothing has been done by the policymakers or the insurance companies to do that. So a lot of people have to change what needs to be done and how we need to do it. So in medical schools, they teach us this is an alcoholic, this is a junkie, this is druggie. We treat the overdose of withdrawal, we get them out, and then they go do the same thing. So that language has to change. Otherwise, nothing is going to improve. So we need to create mandatory seminars. Everybody, medical professionals, policymakers, insurance companies, what is addiction, a better vocabulary, empathy, and humanity. Until everybody's on the same page, we're not going to fix it.
Mm-hmm. Both in another lecture I heard you give, and then also in your book, you said, if someone appears in my office and they're scruffy and they're sort of disheveled and maybe don't have their act together, that's still someone that I need to treat as a patient, as a human being.
Yeah, as a human being. Yeah, I wrote that in my book, yes.
Yes, and I think that's an interesting point. And it's sad to think that not every physician feels that way.
So the problem is everybody has a regular practice, and when these people who are not very hygienic, don't have clean clothes, haven't showered for a month or so, come to your office, no other sensible person wants to be in the waiting room with them. So it took me a lot of courage. I may have lost some patients because they didn't want it to be in the same office. That happens.
Mm-hmm.
But you got to put your good and the bad together and say, okay, I decided to take care of these people, so I'm going to stick to my guns. And so all my patients are there we don't have a long waiting period thanks to COVID, but everybody sits in the waiting area at the same time. And now you cannot tell much difference between the two patients.
Mm-hmm.
I have 85% success rate. These people are working. They're back with families. They go to church. They go on vacation. They buy houses. They buy cars. They come and show the new clothes they have. They'll show me the wallet that is full of money. And they're the nicest human beings I've ever encountered in my life.
That's amazing. Let's talk about that 85% success rate. How do you get there? How did you start? I mean, I'm sure there was trial and error in the beginning.
Yes. So when I started learning addiction medicine, they said every patient should go see a psychiatrist because most of them has psych issues.
Mm-hmm.
So I was sending patients to the psychiatrist, which whoever was available in town, willing to take the patient. And I would find out that based on what I had learned from American Society of Addiction Medicine and reading my textbook of addiction medicine, we were trying not to give more addictive and abusive drugs. So if they are on stimulants or benzodiazepines or narcotics, we tend to keep away from them. But the psychiatrists were kind of doubling up on some of those medications. And so it was creating a problem. And I realized that I would have to take care of these patients myself. Starting in the first visit, I not only make a medical assessment, then I make an addiction assessment, then I make a psych assessment. So I start writing non-addictive, non-abusive psych medications for my patients. So once the mental situation is under control, it's easy to control their addiction. Two conditions, addiction and mental illness, go hand in hand about 2/3 of the cases. So if you get to the right medication where a person is sleeping 7-8 hours, not having racing thoughts, mind is not all over the place, then things tend to fall together. If you just treat one condition, not the other appropriately, then you're not going to have good outcomes. So if you just give buprenorphine or Suboxone to somebody, the success rate may be 50-50. You add counseling to it, it helps. You treat the mental illness properly based on the patient's symptoms, that number adds up. So that's how I got to 85%. There is no cookie cutter thing, but every patient has different needs, different circumstances, and you have to get to the ground level and figure out what's going on and then go from there.
Okay. So it sounds like the combination of not just attempting to treat the addiction, but also treat the underlying psychological behavior led to success, and also some prescription of drugs that were non-addictive, but were helpful psychiatric drugs.
Yes.
And that's where it all started for you?
Yeah, so that's how slowly I started building myself. And when I was researching for the book, I saw the medical school curriculum and I found addiction is not being taught in American medical schools. I was under the impression these psychiatrists were trained to be addiction doctors. Then I looked at their curriculum and I was shocked that they were not taught addiction medicine. And so we have less than 7,000 providers out of 1.7 million doctors, NPs, and PAs who actively provide care to these people with addiction. As a result of only 2.4 million people are in treatment of the 49 million people that are at risk today of dying from drug overdose.
Would you suggest that more physicians, would it be considered a subspecialty of addiction medicine that are, maybe on the front lines, right? Like you are?
Yes. So the problem is funding. Who's going to teach doctors? Because there are not much well-qualified doctors who are in academic settings to train hundreds and thousands of doctors at the same time. In the last 3-4 years, they're trying to train up to 100 new doctors every year on addiction medicine, like a formal fellowship training. But we need about 200,000 doctors today to care for 20, 30, 40 million people. So that's not going to happen overnight. And 100, 200 doctors per year is not going to make a difference. So the federal government in December of 2022 passed a law called MATE, Medication Assisted Treatment Expansion Act, which went into effect June of last year, which said you don't need to have any training or XDA number to write Suboxone. Any doctor can write it. The system was hoping that telemedicine and this MATE Act will improve access to care. In a year's time, we have not seen any significant new uptake of patients into the system. The current patients, my patients, now they know they can do every other month Zoom, so they're using the system, but we're not seeing more new patients into the treatment arm.
Why do you think that is?
Because patients who are not motivated. So there's a study from Portugal that I just pulled up last year. It's a country of 10 million people. They felt addiction was a big problem for them in year 2008. They made a central agency and they enrolled everybody that was in their country addicted to it. And they said, we're going to treat addiction as any other disease. And then they said treatment was not enough. These people were demotivated to do anything. So they created programs to reverse their demotivation. They rehabilitated them, provided education, job training, job placement. And now 90% of their budget is in treatment and social programs and only 10% in law enforcement. They've been doing very well for the past 15 years. We don't need to reinvent the wheel. We need just the will and desire and might to fix the system. But we keep on spending money on failed policies. I mean, there is war on drugs. These opioid money started to come in. And my county had 600,000 to disperse, and they still politically gave to the all failed policies that are not working. Okay, They don't listen, they don't care, nobody wants to fix it.
Right.
So that is the problem. Then there is war against recovery. There's so many factors that don't want people to recover. You can't take Suboxone because it's another drug for a drug. We need to stop those kind of things. We really need to educate all the doctors and promote medication-assisted treatment. Yes, the doctors have a lot of disincentives. 1,000 doctors have been shut down for alleged overprescribing medications. So the others are scared. Once you see in my small town, 3 doctors have been apprehended and they lost everything. So others notice and say, hey, this is not worth it. There is no incentive built to learn and practice addiction medicine The biggest problem a doctor like me faces is a healthy 70-year-old is seen every 3 months in the office, once for annual physical, once or twice they get sick or something. So 6 to 8 times in a year. These addicted patients are very, very sick from so many different angles. So we have to see them 20, 30 times in a year. By that time, the insurance companies are like, what is this idiot doing? He's involved in fraud, abuse, and wastage. So they come and investigate. A lot of stress unnecessary. They haven't found anything. But all these things are wrong, and it prevents other doctors from getting into it.
Yeah. Well, your book proposes solutions to this, and I've heard several things. One is perhaps the wrong emphasis in money, enforcement of laws that are punitive, including on physicians who are attempting to treat it, and insurance companies not liking the fact that you need to see a patient multiple times, maybe more than the insurance company is comfortable with in order to treat this person. As I mentioned in the beginning, even offline, our audience here at the Chase MedSearch podcast is, very practical folks. They're salespeople, and a lot of them are selling to interventional pain management doctors, PM&R, interventional radiology, neurosurgeons, orthospine doctors, and they're doers. They get things done. If you had or could wave a wand and have, folks that hear this podcast and are motivated to go out and try to make just whatever impact they can in their own span of control, what would you have people do at this point?
Well, the Supreme Court heard the case doctors versus the government. And 2 years ago, they said, let doctors be doctors and practice medicine without the fear of laws. But they still do not listen to that. So the insurance companies and the lawyers and just keep on creating more and more problems for the doctors. So unless doctors can practice without intimidation, and then they need their education and then incentivize them. So just a few weeks ago on the JAMA network, there was an article, Why Doctors Hesitate to Treat Addiction. So I'll let you know a few key points. The first important thing was the big institutional support is lacking, means if the biggest healthcare system or the biggest business is willing to support the treatment for addiction, then there is funding available, then there is leadership available, then things will move. Doctors lack knowledge, lack skills, and doctors lack cognitive capacity. We need policies and incentives and training, knowledge, and skill to fight this problem. And then physicians have reluctance to address this addiction across all healthcare settings. Then there are negative social influences, and then there are beliefs that public acceptance towards addiction care, and then the expectations around the benefits. And then the things that we talked about, like, diversion of Suboxone, and then they criminalize the doctors because patients are trading things on the street. The drug company got penalized. And, if they had made Suboxone a non-restricted drug, a commodity like medicine for diabetes and hypertension, we would have all these layers of interference by the policymakers and the insurance companies. Then everybody would be easy to write the prescription and people to get the prescription.
I couldn't say that better. I don't think anybody in America could say that better, Dr. Gupta. I want to thank you for being on today with me and discussing these issues in your book. We will link your book in our show notes, The Preventable Epidemic, a frontline doctor's experience and recommendations to resolve America's opioid crisis. Where can people find you? I know you do speaking events and practical consultative types of talks. How can they find you?
Well, so my office number is 734-241-7162. I think that's the best, least stressful way for anybody to contact. If I give my email, then I'm going to get so many emails, which I don't mind, but I may not have time while working to answer to all those things. So, or they could look at my website, The Preventable Epidemic. I also have a 501c3 called SOS Serious Opiate Solutions. And the $1.25 I get from the sale of the book, it goes to a foundation. So I'm not doing it for money.
Yeah.
And I'm spending my time and my Like I was in North Carolina last month. I'm going to LA to speak to about 200 physicians in 2 weeks. So it's all my time and my dime. And I would like to see, as a physician, as a human being, that it is not appropriate or acceptable that 300 to 400 young, healthy people can die every day. It's like a jumbo jet coming down every day, and nobody wants to do anything about it.
Yeah.
That's totally wrong, unacceptable, should be unacceptable to anybody.
Yeah, thank you so much for taking on this critical issue in the country. And I hope that many, many more people are stirred up to do so. Thank you for being on, Dr. Gupta.
Thank you, Jordan.
Thank you for joining us on the Chase MedSearch podcast. I hope that you gained some helpful insight from today's episode. If you enjoyed this episode, be sure to subscribe so you don't miss future episodes, and give us a like on your favorite streaming platform. It really helps grow our audience. For more information on Chase MedSearch, visit our website at chasemedsearch.com. Thanks again for joining us. Until next time, I'm Jordan Chase, and this has been the Chase MedSearch podcast.